Perfect. So welcome to our May speaker series. If this is your first time attending one of our speaker series, this is one of our digital education events that we do every month, and they're always recorded. And so if you have to hop off early, or if you've missed some previous sessions that we've done, they are all available in our Her library. So this evening, as we sort of move through, I will post that link so you can go and hop back on and just do a little bit more learning about the variety of topics that we have discussed. Most recently, we've talked about things like metastatic breast cancer in the Black community. We've talked about cancer-related cognitive decline. So we've talked about lots of different topics, and we do this every month. So we're just about planned through the end of 2022. So we've got lots more discussion to come. So again, I want to give a special thanks to our sponsor, Merck, because they are huge sponsors of our entire digital series. So we are very grateful for them. Just a little housekeeping before we hop on with our first speaker. I do ask everyone just to keep yourselves muted. If you have questions, you're welcome to raise your hand, or you can put them in the chat. We will be monitoring the chat as we move through, and we will stop and engage, whenever we have the moment. Dr. Hanley, who is joining us in just a moment, will be here for the first half of our session this evening. So once he's finished presenting, we'll have time for questions with him. Anything that we don't get answered today, know that we will pass along to him, and we'll have in our Her library for you. So certainly grab your pens and pencils and get ready for learning. Just one more quick reminder. So this is a monthly series. So just putting on your calendars that our next speaker series will be Thursday, June 2nd, as usual, starting at 6 p.m. Eastern time until 7. It will be recorded. We'll be having some fun outdoor activities with our friends from Lancaster Farm Fresh and Lancaster Pharmacy. So we'll be having some fun with that. So with that being said, I would like to introduce our first speaker. So covering the medical side of bone health, Dr. Hanley, I will bring you on the screen with me. So Dr. Nathan Hanley is a medical oncologist at Jefferson Health and an integrative medicine fellow at the Marcus Institute of Integrative Health. And I know, Dr. Hanley, you've joined us recently for one of our wellness days, and we loved your whole approach to health and wellness. And so that's why we thought it would be really wonderful to have you with us this evening. So thanks for joining us.
Yeah,
I know.
Just a reminder again,
Good,
we want to keep ourselves muted. We're hearing some background noise, so we don't.
I went and got a PCR test yesterday at Walgreens.
All right. I hope you were negative, whoever got a PCR test. But if you want to go ahead and mute yourself, that would be wonderful. Dr. Hanley, thanks for being here with us.
Yeah, thanks, sir.
You're welcome. Let me share my screen for you and we'll get started. Okay. Can everybody see that okay? Whoops.
Yes.
Good. Okay, go ahead.
Okay. Yeah, looks like it's good. All right. Well, thanks everyone for joining here today. And I'm just realizing I have my window open and there's a little bit of noise outside. So if that becomes a problem, just let me know and I'll close the window. But it's so nice outside, it's hard not to have the windows open. So today we're going to be talking about bone health for cancer survivors. And when I say cancer survivors, I basically mean anyone who has had cancer at any point, whether you're just diagnosed, whether you are you have had treatment, whether you're continuing to have treatment. This should be relevant for all of you, regardless of if it's breast cancer or ovarian cancer. These concepts are all relevant. Erin, if you can go to the next slide.
Mm-hmm.
So why are we talking about this? Why does bone health matter? It's because bones are really the foundation of the body. They're the scaffolding on which everything else rests. Bones are actually a vital, dynamic connective tissue, and they have several important functions. First, they provide the foundations for our mobility. So muscles connect to tendons, and tendons are anchored to bones. And so they're kind of really the support for the whole musculoskeletal system. Second, bones protect and support vital organs. So they're the kind of the scaffold in which organs can exist. Third, they serve as a mineral reserve for a lot of really critical minerals that are used for a lot of different functions of the body, like calcium, magnesium, phosphorus. And fourth, the bones themselves actually hold tissues that are important for a couple of different things. One is they hold the bone marrow, which is involved in the development of blood cells. So that this is something called we call hematopoiesis. And then they also are they restructure themselves. So they hold all the components for redesigning themselves. Next slide, please. And so bones are actually part of this complex organ system that is constantly changing. Bone tissue is constantly being broken down and rebuilt in a process called the bone remodeling cycle, which is in this figure here. So in this process, bones are resorbed by cells called osteoclasts, then reformed by cells called osteoblasts. So in a normal state, this remodeling and modeling activity serves to reduce bone mass in areas where there are fewer mechanical demands on the bones, so areas that are not getting as less activity, and form bone in areas that have a lot of activity, where demands are high. So if someone is walking every day, then bones in their legs are going to be stronger, whereas if they're not, then those bones are not going to be as strong. And so this happens in a very structured way, and if it happened randomly, the bones wouldn't necessarily be equipped to serve the mechanical or the mineral needs of the body. You might see big fluctuations in mineral levels. You might have a mismatch between which bones need to be strongest versus which bones are actually strongest. And so these changes are highly responsive to the needs of the body and the needs of the environment. And it's this delicate balance where external mechanical inputs and kind of physiological signals from the environment lead to changes in the cellular level and changes in mineral levels. Go to the next slide. And so bone health changes over the course of someone's life. For both men and women, the peak bone mass is achieved in their mid-20s. And then after that, everyone has a gradual decline. And that decline is very gradual for men. For women, there's a plateau that occurs, and then that is followed by an accelerated period of bone loss for several years after menopause. And so you see that in this figure where there's the kind of the steeper drop off after menopause. And this is because the remodeling process just over time tends to result in a negative bone balance. We'll talk about that a little bit moving forward. So we can go to the next slide now as well. And so when the bones thin, this negative balance of the bone remodeling cycle can lead to something called osteoporosis, which is we also sometimes just call thinning of the bones. So if you look at this image here on the right side of the screen, and this normal bone on the left side of the screen is the kind of osteoporotic bone, which has bigger spaces. It's kind of honeycomb looking. That's kind of an illustration of what is happening. So this is sometimes, osteopenia is another phrase that is sometimes used, and that is used to describe less severe conditions of weaker bones. But both of these conditions are silent because bone loss can happen without you knowing it, and generally does happen without you knowing it. The problem is that having osteoporosis can predispose the bones to fracture with even pretty minimal trauma. And fractures that result from osteoporosis can result in a lot of problems, a lot of pain, disability. And osteoporosis is actually quite common. In the US, there are about 44 million Americans who are at risk for osteoporosis, and 10 million of those already have osteoporosis. And I think most importantly is that women make up 80% of cases of osteoporosis. And so here are some of the risk factors that can predispose you to osteoporosis. So we saw that age is an important risk factor, but there are some other factors too that can accelerate this process of bone loss. And many of these things make sense when you think about how bones grow and what they're made of. So remember, the bones are this complex system that responds to external mechanical inputs, like repeated use from exercise. And so, so people who are thinner, who have a smaller frame, there's less weight to kind of stress the bones in some ways. And so that people who have a thin or small frame are at higher risk. People with a family history of osteoporosis may have a higher risk. People with less physical activity. And then people have low calcium intake because calcium is needed. Even if there's a lot of kind of exercise and physical activity, if there's no structure to build the bones, no materials for building the bones, that can put you at risk. And then there's some other factors like smoking, excessive alcohol use, and then the prolonged use of steroids or chronic inflammation through kind of a complex mechanism can lead to inhibition of bone growth. And so that's all true for people in general. And if we go to the next slide, there are some more specific risk factors that are relevant for women with breast or ovarian cancer. And so women who have had treatment for either of these cancers are at higher risk for a couple of reasons. The biggest of which is there's a loss of estrogen that can happen. And so people have abnormal or absent menstrual cycles, people who are postmenopausal or at early menopause. These are all patients who are at risk for osteoporosis. And there are also, a number of treatments that can do this. So surgery that can affect the ovarian function can lead to a drop in estrogen levels. And then, as some of you may have experienced, women who are premenopausal before their treatment may go through menopause earlier than those who have not had breast cancer. And so the reason estrogen is important is that it's a major stimulant for the osteoblast activity of the bone remodeling process. And so the blasts, again, are the cells that build bones. But we're also finding that even if all of that is still normal, if your estrogen levels are still normal, if you've had chemotherapy or radiation, you may still be at risk for osteoporosis. And we're finding, there have just been some studies in the past year or so, finding that chemo and radiation can cause bone loss by this complex process that basically leads to quiescence of bone cells, which means that the cells essentially become dormant and they don't work the way they were previously working. And this has been shown in some large NIH studies, basically that women with breast cancer, specifically breast cancer survivors, have an increased risk of fractures compared to age-matched peers. Okay, next slide. So what does this look like for women with cancer treatment? And this is an example that I think is a good illustration. And this is specifically for patients with breast cancer, but is really relevant for many patients with ovarian cancer too. So if you think about what happens with bones over time, healthy postmenopausal bone loss is usually about 1% to 2% change in mass per year. If you've had tamoxifen, if you're looking, I guess that's like 2N, tamoxifen can kind of have this differential effect. So for patients who are postmenopausal, tamoxifen can actually increase bone density by about 1% to 2% per year, which is what we're seeing here. But for patients who are premenopausal, tamoxifen can cause bone loss. That's about 1% to 2% per year, which is essentially equivalent to menopause, the losses from menopause. For people on aromatase inhibitors, the loss is more significant. And those can cause bone loss at 2% to 3% per year. And then things start to get a little bit more prominent. So if patients have something called chemotherapy-induced ovarian failure, which is what the OF here is, so that's basically chemotherapy that's causing the ovaries to not work as well, then the loss is about 7% per year, 7 or 7.7% per year. And those losses are higher still if people are getting something called GnRH agonists. And so those are things like Lupron, which some of you have probably had experience with. And that can cause about 8% bone loss per year. I think what's also interesting is that in premenopausal women, if you're combining some of these different therapies, the bone loss can be up to 11% per year. But despite those significant losses, premenopausal women may not need osteoporosis treatment because they're closer in age to their peak bone mass. So to the next slide, what do we do about this? What do we do about bone health? So in 2019, ASCO, which is one of the big professional societies for cancer, put together this multidisciplinary panel to develop guidelines for the management of osteoporosis in cancer survivors. And they looked at a lot of literature and basically came up with a couple of recommendations that include screening, some lifestyle interventions, and some drug therapies. So we'll talk about screening first on the next slide. And for screening, so there are a couple of tools that clinical teams think about. One is a risk assessment tool. And so a commonly used one is something called the FRAX, or Fracture Risk Assessment Tool. And that's used to quantify the risk a particular patient has of having a fracture. And so this tool and tools like it often include some factors that are known to cause bone loss, some of the things that we talked about before, like smoking or steroid use. And so we can plug in these numbers and get an estimate of the risk of a fracture in 10 years. And so if people have a 20% risk of a major osteoporotic fracture in 10 years, or a 3% risk of a hip fracture, those are often triggers for us to think about medications for bone strength. And so the FRAX is one tool, but for patients with cancer, we think about it a little bit differently. We have a lower threshold often to think about medications for bone strengthening. And so essentially any patient with cancer who has one or more risk factor for osteoporosis is considered at risk. And so those are the risks that we talked about before. Advanced age, well, not that advanced, ages over 65, smoking, alcohol use, low estrogen, things like that. And so for those patients, any patient who we consider to be at risk, we recommend something called a DEXA scan, which many of you have probably experienced. And so a DEXA scan is a specialized test. It's pretty straightforward. It stands for dual energy X-ray absorptiometry. DEXA is much easier to say. And it gives you a score, a T-score, that compares you to a healthy population. And if your score is at a certain level, then we would recommend considering treatment. And so to the next slide, what types of things do we recommend? And so there are lifestyle interventions that we can recommend. So there are some nutritional things to consider. Erin's going to tackle that. There's physical activity considerations. Priscilla's going to talk about that. And then we've seen that smoking and alcohol use can be risk factors for developing osteoporosis. And so those are things to consider as well. And so the next slide, we'll talk just very briefly about drug therapies for osteoporosis. And some of these are drugs that some of you may have been on or may be on at present. But essentially, for patients with documented osteoporosis, or if patients have significant increased risk for osteoporosis, we recommend these things. And there are a couple of drugs that are approved and frequently used. The two major drugs, two classes of drugs, are something called bisphosphonates. And an example of a bisphosphonate would be zoledronic acid. And another category is the RINC ligand inhibitors. And these both work in slightly different ways on the bone remodeling process. But essentially what bisphosphonates do is they inhibit osteoclasts, which are the cells that break down bones. And what RINC ligand inhibitors they do is a little bit more complicated, but at the end of the day, they do the same thing. They also inhibit osteoclasts. There are some other drugs here as well. Teriparatide, for example, is a parathyroid hormone analog that can be used, but is not typically a first-line treatment. And so these are therapies that we often consider. Hormonal therapies are sometimes considered as well, because estrogen is something that can help bones grow. But for patients with cancer that has kind of been hormonally responsive, it's not something that we would consider. So there are kind of rare circumstances, or some circumstances where we would, and some where we wouldn't. Okay, and then I'll run out of time here. There's a lot to say. So I'll go to just one last slide, which is that I think one of the things that I recommend for most of my patients is acupuncture, because it can be very helpful for managing many of the side effects of cancer and its treatment. And while acupuncture is not included as a therapy in a lot of national guidelines, there is high quality evidence for its use in a lot of cancer symptoms, including things like joint pain from aromatase inhibitors. And there's growing use for its use in osteoporosis as well. And so here's just kind of a couple of examples, but there was one large meta-analysis of 35 different studies that looked at over 3,000 patients and found that acupuncture could increase bone density in various areas, could reduce pain, and it, had a couple of other positive effects. And so I think for many reasons, acupuncture is something worth considering during treatment. And I typically refer patients to the list that Unite for Her has of acupuncture practitioners, which is kind of a national list that you probably are all familiar with. So I'll end there. I'll just say that many patients with cancer who have had cancer can be at risk for osteoporosis and at risk for fractures. And so there's a lot that can be done. There's screening that can be done with a DEXA scan. And then there are a lot of interventions that can be helpful, which may or may not include drug therapies. And those are things like nutrition, exercise, lifestyle modifications, and then potentially addition of a drug like a bisphosphonate or a RINC ligand inhibitor. So I'm actually stopping there. And okay, went a little long, but still have some questions.
That's okay. Yeah, we have some questions if you have a few moments, because we know that you have to pop off. But if there's any questions you want to touch on, and just as a reminder, anything that we don't get to that is relative to Dr. Hanley, we'll pass along to him, and then we'll post again on our library.
Okay, so let's see. I'm looking at some of these questions here. How do you test for quiescent cells? Ooh, that's a tough question. And I think the short answer is we don't necessarily have a good test for it. And so what we do is really just see what the effect of quiescent cells could be. And so if someone does have quiescent cells, then that would eventually show up in a DEXA scan. And so we basically would just do screening DEXAs, which is relevant for another question from Felice, who asked why do you have to do the repeat DEXA scans, basically? And so during treatment and after treatment, we do recommend repeating DEXA scans. And so no more often than once a year, and generally once every 2 years is okay. But the reason for that is that things change and the bones change. The bones are a living complex system. And over time, naturally, there tends to be this decrease in bone density. And so we repeat the DEXA scan to see what kinds of changes are happening, and if it's happening at an expected rate or not at an expected rate. And so changes in treatment, a different chemotherapy, a different regimen might accelerate bone density changes more quickly. Trish asked about things like caltrate and D, and I think that's going to be a great question that Aaron is probably going to address. I had it in mind, but I didn't talk about it because I ran out of time. But yes, there's that's definitely something to consider, and a lot of kind of national guidelines to recommend specific dosing, which I imagine Erin's going to talk about, so I won't steal her thunder there. Let's see, Carolyn talked about metastatic patients with bone mets. Yeah, there is a lot. That's another big topic, and so we will file that away as something to think about. Trish, let's see, is there a difference in risk between chemo-induced ovarian failure versus surgical removal? Not that I'm aware of. They both have very similar impacts on the body, actually. And so, yeah, if someone has an oophorectomy versus is on Lupron or something like that, those are they're similar in our eyes, essentially. The risk is very similar. Susan is asking about manganese. So, there are a number of minerals and micronutrients that are relevant for bone health, and we do tend to focus on calcium intake We talk about vitamin D a lot, but there are a lot of bones are complex, and we focus on calcium, I think, in part because it is such a prominent feature in bones. But things like manganese is relevant, vitamin D is relevant, phosphorus is relevant. I imagine Erin might be covering some more of these things as well. Let's see.
Dr. Hanley, I want to be mindful of your time. I know we're running a little bit short. There are so many great questions and suggestions. So I'm happy to continue to pass some of these along to you as we sort of move through.
Yeah, and happy to do that.
Perfect.
Annette was asking about the list, the acupuncturist list, and so I know that's on your website.
Yep.
Yeah. Okay.
Wonderful. Well, thank you so much for being here and sharing this with us. We appreciate your, I'll hop in here. We appreciate your time and sharing this information. And yes, Caroline, I wrote down that we will look at having a bone health topic centered with our metastatic community specifically, because, we're talking about bone health overall, but we love that suggestion. So we'll definitely be returning back to that. So we thank you. And Dr. Hanley, thank you again for your time. We appreciate all of the knowledge that you impart and being part of our community. And we appreciate you, being so supportive and joining us this evening.
Yeah, thank you. Thanks,
You're
everyone,
welcome.
for your questions. I'm happy to be here. Okay,
Thank
thank
you.
you.
Okay, so as I said, we are recording, so we have all of your questions in the chat. So anything that we didn't get addressed, we love these questions. We will pass along to Dr. Hanley, and we'll make sure to post those questions in her library. I will add that link as well. So we've covered the medical side. We heard Dr. Hanley talk a little bit about the importance of lifestyle and movement, and we have one of the best in the business joining us this evening to do some practice with us. So let me pull up Priscilla to have her join me. There we are. Wonderful.
Hi.
Hi. So for those of you that may not be familiar with Priscilla, she is part of our Unite for Her provider community as well. She is a cancer exercise specialist. She's part of the ACE program, cancer and fitness certified instructor. And of course, she is the founder of our Stronger Through Cancer virtual exercise program. And I know at our wellness days, when she gives our talks, she does talk about, her classes and how they can help with bone health. So she will be showing us just exactly what that means, which we love it. So Priscilla, thanks so much for being here.
Oh, thank you, Erin. And thanks, everybody. Hi, everybody. I'm so happy to be here to talk to you guys about the importance of regular exercise and bone health. And I'm going to try to keep this short since Dr. Hanley rightly went over. So we all know that exercise is good for us. I know we know that, right? And many of us have actually maybe, I don't know, transformed ourselves physically and even mentally through exercise at some point in our lives, all right? So the reality is we know that it makes us feel better. Regular exercise will give us more energy, help us sleep better, help us handle stress better. But the science is it can actually help us age better as well. And functional aging is, on everyone's wish list. We all want to be able to do the things we like to do for as long as we can do them, right? But unfortunately, when we're talking about cancer, and I'm a cancer survivor right there with you, much of the cancer treatment, and somebody's not muted, just so we know. Some of the cancer treatments and medications that we are on and have gone through have long-term health effects. And we just heard Dr. Hanley talk about that. But the other fact is that bone, like muscle, is a living tissue, and it does respond to regular exercise. It can get stronger. So throughout our childhood and adolescence and early adulthood, right, our bones, as he said, absorb minerals and nutrients, and they gain strength. And then as we enter older adulthood, and not even that older, we begin losing our bone strength and bone mass and our muscle mass as well. And often those medications and things like that can, accelerate that process, leading to things like osteoporosis. But the good news is we can make them stronger through regular exercise. You've been listening for a while, and let's see if I can find a universally liked song. All right, everybody likes the Foundations. All right, so that might be walking in place, right? Maybe you're somebody that just wants to do this. Maybe you want to sway. Everybody has their own way of kind of moving. Maybe you want to give me some high kicks. I just want you to move while I'm talking, all right? Just see how it feels. Nobody's looking at you. Doesn't matter to me. All right? And as you're moving, think about moving all the many parts of the longer muscles in the body. So we've got legs, we've got arms, right? Just get them going. Doesn't matter what you look like, what you're doing, you're moving. That's right. Just be moving. Now, I'm looking like an idiot, and I don't mind, because you're looking at me. I don't know what you're doing, but I'm trusting you. I'm trusting that you're doing it, all right? Good. Okay. I want you to be very present as you're doing this, and start to think, what am I feeling? Do my knees hurt? Am I like, this is silly? Because this is just the beginning, okay? And then I want you to stop. And I want you to take in a couple rounds of really deep breath, right? Really deep breath, filling up your lungs. Really linger with that long, slow exhale. Yeah. That's it. Maybe again. Just take a moment to enjoy the sensation, right? Of that, the movement and the breath kind of just washed over you. And then think about something here. How you feel right now. Just a few moments of that movement has already begun to make some physiological changes inside of you that's created those things that you just felt. Okay? So imagine what would happen if you did that on a regular basis. Okay, so we're going to do some things together. And I like this. Okay, so already, not already, I shared with Erin earlier today something that hopefully you guys can use, and the exercises that we're going to do are on the second document that I'm sharing. The first are my 3 S's, which I talk about a lot in these presentations. But we're going to skip that right now and just start to move, okay? And this is for my friends with metastatic disease or cancer on its own, okay? You can do all of these things without any equipment in your home. The first thing that we're going to do together, you guys, are wall push-ups. So you want to be near a wall. And if you just want to watch for now, you're like, not happening, that's fine too. So I'm going to go over to the wall, and what you want to remember about wall push-ups is that the closer you are to the wall, the easier it is, okay? You want your hands about shoulder distance. And you want to tighten up your core and your butt. So you're kind of squeezing together, almost like you're bracing for somebody to come at you, okay? Hands shoulder distance, closer you are to the wall, easier it will be. And what you're going to do is position your hands slightly turned, zip everything up, bend at the elbows, and bring your chin and chest towards the wall. And then push back. One more. And then push back. One more. And then push back. We did 3. How did it feel? Take a moment, just think. How did it feel? Do my wrists hurt? Do my elbows hurt? Now, if you've got meds and you don't want to do any weight bearing, remember, you don't have to be that far from the wall. Then we're going to take that same wall and we're going to work on a different set of muscles. We're going to work on our large muscles, the biggest muscles in the body, the quadriceps, okay? So come over to the wall with me. And what I'm going to have you do is a wall sit. And when you're doing a wall sit, please remember your knees are under your hips, okay? So you get your back right up against the wall, take your knees about hip distance apart, begin to slide down. If you feel unsteady, you can have that chair right next to you to hold on to. And you see how my knees are under my hips? It's a nice safe distance. I'm gonna pull my navel in towards my spine, and I'm gonna plug my shoulders in. And I'm gonna see if I can hold this while breathing for 30 seconds. We've probably already been here 15, so let's just say 15 seconds now. Make sure you're breathing. You might be shaking, that's okay, they're working. And then we press out of it to come up. And one way you can integrate the arms with that little move right there is you can watch me for a second. You come into your wall sit. Again, knees under hips, navel plugged to the wall, shoulders plugged to the wall. And what you can do is extend your arms forward, make little fists with the thumbs outside, and pull the elbows back like you're pulling a cable back. Forward, back, forward, back. Push off from the wall. Try that 3 times. See how that feels. All right? Maybe you did it with me. I don't know. That would be kind of
Priscilla, we did
Yes.
have a question.
Yes.
Someone is asking, what do you mean knees under hips?
Okay, that's a good question. I found out that one of my dear members was trying to keep her knees in the same line as her hips. And I can tell you, unless you're really, really practiced at that, that's gonna be really hard. So when you're sitting on the wall, you wanna be able to see that your knees are below where your hip bones are. Does that make sense?
Yeah.
Okay, good. And these are wonderful questions. That's a wonderful question. And these are things that we can talk about. If you were working with me on Stronger Through Cancer, these kinds of questions come up and then we deal with it right then and there so that you're in proper alignment, you're safe, and we move forward successfully. All right, so we've done a wall push-up, we've done a wall sit. Let's move away from the wall. One of the powerhouse moves that you need no equipment for are squats. And believe me, I've worked with hundreds of people, many of whom have had bad knees. I'm a former runner, I have terrible knees. And people think they need to avoid squats because of knees. But actually, you want to build up the muscles around the knees. And these are big muscles. Trust me, they can handle it. But if you're nervous, or let's say you're unsteady, or let's say you've got neuropathy in your feet and it just feels lousy to be on them and try to come into a squat, you're going to use a chair and do a little bit of a sit down, stand up halfway. See how my knees are under my hips again? Down, come up halfway. Now to make this a more impactful squat, when you come up, you squeeze your butt and you sort of manually shift your hips more forward. It ignites these muscles, okay? Let's see if we can do 3, and you can either do them in the chair or just with me. Couple things to know about your squat. If you feel like you need a wider stance because you've not done a lot of them, you're not practiced at them, take it wide. Almost like a plie is fine, okay? And then when you go down, what you want to do is keep your chest from going down like this. We're not picking up something, we're not an ape. We want to keep our chest as high as we can. It's going to go forward, of course, but we don't want to have it facing the ground. So you go as low as you're comfortably able to. I always tell my friends, try to stick your butt back like you're trying to find the chair. And when you come up, give me that squeeze and that shift forward and back down. We're going to do 3. That's 2. And 3. All right? Already feel it? I bet you do. Shake it out if you need to. A little shake out. So we've done 3 squats. We're going to use the chair for the next leg moves. Holding onto the chair, again, you don't have to if you feel particularly stable, but for things that involve taking one leg off to the side, I like to have my members use chairs because you can suddenly be off balance without expecting it. And we're going to do what I call leg swings. So we're going to go in 3 directions: forward, to the side, and back. But we're not just going to swing, we're going to control the muscle, right? So hand on the chair, you guys. My outside leg is the leg that's working, and what I want to do first is contract the muscle. So I sort of flex my foot, and without moving my belly, my lower back, I want it isolated with my legs. I'm going to bring it out, front, back, out to the side, back, and then for this move, squeeze your butt and take it back. We're going to do 3 of those. Ready? Here we go. Forward, isolated just the leg, out to the side, back, squeeze the butt. Good. Yeah. Forward, out to the side, squeeze the butt, back. Now I don't want you lopsided, so we're going to do the other side, because we did 3. And remember, the outside leg is the working leg. Hold the chair, contract that muscle, so flex your foot, isolate it, out to the side, out front, to the side, and back. 2 more. Now this would be a lot more challenging if you had like a exercise band around your thighs. That's something that you could work towards, or even those ankle weights. That's 3. Do you feel it? I bet you feel it. Okay. All right, so those are a few moves that you can do for your legs and your arms. The push-up at the walls for your arms, and the pretend cable pullback is for your arms. But here's the biggest one of all that everybody loves because everybody knows it, and it's a great one to build muscle, and that's the bicep curl. And if you're just starting out, you do not need to use weights, okay? And if you are one of my friends dealing with METs, you don't use heavy weights. You can use, well, I happen to have some light weights, but you could use a can of beans. You could use some water bottles. If you feel like, well, I'm ready for weights, or I want to try weights, but you don't want to buy them, use that. You're going to hold them here next to your sides, and the palms are facing me. And I like a little kickstand with my foot to support me here, rather than standing straight. And also, hint, kickstanding one leg back keeps you from arching in your lower back, because you want to isolate these things to the muscles you're working, just the arms, right? So we're going to do it together. We're going to bring them up, keeping our elbows close to our ribs, and here's the rub. Give them a little squeeze, like you're trying to press a piece of paper between the weight and your shoulder blade. And then back down. That's 1. Up for 2, give a squeeze, down. And up for 3, give a squeeze, and down. So that's a bicep curl, works the front of the arm. Let's work the tricep, which is the back of the arm. Again, you don't need weights, but if you've got them, that's fine. So the tricep extension is really great for us, especially if we're dealing with any kind of posterior deviation, which can happen after cancer surgery or any kind of breast cancer involvement, because there's this tendency, it's almost like a natural instinct to kind of round in to protect this area when you want to kind of expand and open it, all right? So we want to keep ourselves nice and open. Tricep extensions are easy to do that with. You start here, and from the side I'll show you. You're just going to send them back and then bring them back to the shoulder. So I'm keeping my elbows close to my body, and again, sending them back as far as I can extend them, back to the shoulder. Give me 1 more. Back to the shoulder and relax. Do a couple shoulder rolls, they feel great, or shoulder shrugs, and that's it. Now, you did 3 of these, hopefully. I wasn't just doing this by myself. 3 of them. And if you felt like that's it, that means you can do more. So I often tell people when you're just starting out, do 3 to 5, 2 times. So you could do that whole thing, a wall push-up, a wall sit, a squat, the leg swings, the bicep curls, the tricep extensions, 3 to 5 repetitions of the movements, and then repeat the whole thing a second time. So you've done 2 sets of 3 to 5 repetitions. And this is all on the paper. I'm not expecting you to remember everything. But that's just an example of a little bit of a workout. It didn't take very long. And I'm breathy, okay? I don't know if you feel that yet or how it felt. But what I want you to do is just like we did at the beginning, take a moment, really be present. Think about how your body feels. Yeah. Take a really deep breath. I want you to linger with that exhale, blow it out nice and slow. And there's that feeling again, I hope. And hold on to that feeling. And remember that you can sort of curate that feeling and give it to yourself more for longer periods of time and more regularly, and it will make the changes. It will make the changes. You can make your bones stronger. And final thing here, for especially for my metastatic friends, I've heard of it, I saw that in the chat, I get it. You want to increase your mass, right? It's going to help with daily living activities. Things that feel hard, ordinary things like grocery shopping and vacuuming and picking up grandkids or picking up children. Building muscle mass not only protects the bones, but it also makes daily activities easier. So I hope that was helpful. I hope you enjoyed it. And yeah, thanks. I hope everybody liked it. Thank you.
Priscilla, we had great movement. I was watching everybody moving as you were moving. It was wonderful. Yeah. That was wonderful. So I attached Priscilla's sheet in the chat. I will be emailing it to all attendees afterwards. So you will be getting it, her 3 S's. I love it. We did have one quick question before I quickly review nutrition. For our ovarian community. So wondering if you have any suggestions for ovarian, specifically core abdominal exercises, upper thigh for post-surgical strength. Great question.
Definitely. That's an outstanding question. And yes, you do. I will tell you, it's easier for me to tell you what I don't want you to do. I don't want you to do crunches. Listen, I have very strong abs, but as I say, they're surrounded by bread and wine, okay? But they are there. And they are strong, and I don't do crunches. I hate crunches. So here's one thing I want you to think of, because if you join Stronger Through Cancer, we would work on this. But I want you to think of your abdominal muscles as trying to lengthen them. So imagine you've got a little tiny wire on your sternum and a little tiny wire on your belly button. And what your job is every day is to try to keep that wire tight. Don't let it slack. Keep it tight. So any movement that you can do that reinforces that, and here's an example. You could do a standing stretch back, kick back, okay? And if you don't like taking your arms overhead for maybe you've got range of motion issues, it doesn't feel good, this is fine too. Just keep that line open as you do it. And the idea of the step back involves the upper thighs and the groin, so that's helpful as well. I hope that helps.
I love that. Thank you.
Yeah, you got it. Thank you. And thank you, everybody. I hope you hear how much I care. I really do. And I also hope you will check out the free trial. It's there all the time. Give yourself 2 weeks to see what you think of Stronger Through Cancer and join us. We've got a great community going. Thank you.
Definitely. Thank you. So as I said, so I'm going to quickly cruise through nutrition. Priscilla will be hanging on for the rest of us, and then we'll have a few minutes to tackle some questions at the end. But she is a wealth of information, and we love her and her energy, and she makes everything accessible and like we can all feel like we can all do it. And we love that. So I am going to quickly share my screen as well, just to cover some nutrition topics that come across quite a bit. All right. So let's talk nutrition for bone health. Okay. And this is, like I said, a topic that comes up quite a bit in our nutrition chats. And I love that. So so we are talking about calcium first and foremost when we think of nutrition. So it is the most abundant mineral in the body. If you think about it, all our bones, our teeth, made of primarily calcium among other minerals. So it's the most abundant mineral, which I thought was pretty interesting. For how much an average adult needs per day, anywhere from 1,000 to 1,200 milligrams per day. The NCCN recommends 1,200. I think most of us know that number. Now, what came up earlier, and I want to see if I can move this down a little bit. One of my controls. Perfect. So this came up, and this question comes up a lot. There's different types of calcium supplements out there. If that is something that you discuss with your medical team that is appropriate for you. So let's talk about the 2 different types of calcium supplements that are out there. First is calcium carbonate. So calcium carbonate is by far a calcium supplement that contains the highest amount of elemental calcium. So it's the best value for the buck. Now, one of the most important points to know about this is it requires stomach acid in order for its activation. So we'll get to why that's important in a moment, but that's why it's often recommended to take with food and a better choice for some of us. It's often well tolerated. So this is most people do just fine. If anybody reports any sort of mild discomfort, it's mostly constipation, feeling a little bit bloated, but generally speaking, most of us tolerate them just fine. And some examples of calcium carbonate are things like Oscal and Tums and Caltrate. So we had a question about Caltrate earlier as well. So that's an example of calcium carbonate. Now, we've also got calcium citrate. So this is the most easily absorbed form of calcium. One caveat, this is the form, if you are taking a PPI, Nexium, lansoprazole, any of the proton pump inhibitors for acid reducing heartburn, we would recommend that you take a calcium citrate because you don't have that stomach acid that calcium carbonate requires to help its breakdown and absorption. The problem is that as you see, there's less elemental oxygen, calcium. So it's about 21% calcium by weight. So there's just a little less to it, which means you may need to take more of them depending on how much you're getting from your diet. So examples of calcium citrate are things like Citracal and this brand from GMC, Calcimate Plus 800. So I think most common calcium carbonate is what we see most commonly, but I thought this was important to bring up because a lot of us may have some issues with acid reflux. So for that PPI, worth noting. So let's talk about food sources of calcium. Some of these are so obvious. We know dairy are good sources of calcium, but not just cow's milk. So one of the things we don't know is that for those of us that are vegan or that choose a plant-based source of dairy, those dairy foods are fortified with calcium, vitamin D, and often B vitamins as well. So both cow's versions and plant-based versions are good sources. Also, some of our fish products, salmon, sardines with the bones, when they have those little bones, that's where we get a lot of that calcium. Blackstrap molasses, if you love it, is actually a really great source of calcium. Sesame seeds, tahini are among the highest sources of calcium. Some of our nuts, like almonds, tempeh, and of course our greens, all great source of dietary calcium. Now let's talk about absorption because it can be a little bit challenging. So what you may not know is calcium, whether it's coming from a food or whether it's coming from a supplement, is better absorbed in small doses. We're talking about 500 to 600 milligrams at a time. So if you are taking a supplement and you're taking 2 at a time to meet your needs or as discussed with your medical team, I often recommend separating them and taking them at different times of day so that we really maximize absorption. One of the things that Dr. Handley talked about are these bisphosphonate medications. If you are taking any of them, examples include Reclast, Boniva, Fosamax, Actonel. You want to be taking calcium separately if that is also part of your routine. And so 2 hours before or after, taking them separately. There's also some medications that you should be mindful of that can affect absorption of calcium. Iron, so iron and calcium actually compete for the same absorption sites. So I often say, if you're also taking an iron supplement, again, you want to separate, give yourself some time in between so we really maximize absorption. But also levothyroxine or Synthroid, phenytoin, which is for seizures, some antibiotics. Just worth noting that if you're taking any of those medications, again, you just want to separate when you may be taking your calcium. Another interesting note is calcium's relationship with vitamin C. So vitamin C helps actually increase our body's ability to absorb calcium, which is often why if you've ever bought commercial orange juice, you may see orange juice with vitamin C. Or with calcium, I should say, because oranges are a good source of vitamin C. We add calcium to it, and now from a supplemental standpoint, those two go hand in hand. But you don't have to consume that in order to get that lovely combination. But I often recommend just including vitamin C foods, which are very common. And if you're eating fruits and vegetables, you're probably doing just fine, but incorporating them throughout your day. So strawberries, yellow peppers, in fact, all of our colored bell peppers, orange, yellow, red, great sources of vitamin C, are greens, obviously citrus fruits, Brussels sprouts, broccoli. So again, just sort of incorporating them throughout your day, and you're just assisting with your body's ability to absorb calcium. And then vitamin D, we know the relationship. Those two go hand in hand, calcium and vitamin D. So they sort of activate each other in the digestion process. So yes, it helps our body absorb calcium. Most of us are actually getting less than we actually need because it is difficult to get the recommended dietary vitamin D that we need. What is that? So most adults need about 600 international units or IUs, or 15 micrograms you might see on some bottles, but most numbers are in international units. And so 600 IUs is the recommended daily allowance just to maintain healthy bones and help with calcium absorption. Now, that number goes up if a person, I should say, is in a situation of having bone breakdown, bone disease, decreased bone density. So it can go up to as much as 2,000 IUs, which sounds like a lot, but it really is not a lot. Other sources of vitamin D. So of course we mentioned supplements. We know that it's not very common in food, which is another unfortunate thing, which is why a lot of us are supplementing. I'm often asked about nutrients and supplements, and vitamin D is one of those supplements that I say, most of us probably need to be supplementing with it. But we can also find it in our fatty fish, in the yolk of an egg, beef liver, if you like beef liver. I don't know how much of us are eating that. Some of our mushrooms, and obviously fortified foods that we mentioned, things like orange juice, our cows and plant-based milks, and some breakfast cereals are also fortified with it. Now, some of you may be thinking, well, I thought you could make vitamin C from the sun, which you can in our skin. But there's a lot of things that decrease our body's ability to create vitamin D2, which is then activated and turned into D3. So the season, summer versus winter, and how close we are to the sun, the time of day, the length of the day, cloud cover, the amount of melanin we have in our skin, if we're wearing sunscreen. So all of those things are variables that affect how well our skin is at creating vitamin D. And that's why it's so difficult for us to have really tried and true guidelines for some sun exposure. So some researchers say, 15 to 30 minutes between those sun hours of 10 to 4, a couple times a week without sunscreen is appropriate. But, we also want to be mindful of protecting our skin and sun exposure. And so you might not feel comfortable. And depending on the hemisphere where we live, some of us are in the Northeast, and I've read articles where we're never getting enough sun exposure or close enough to the sun to really make a difference. So it's really hard to have definitive guidelines. Other nutrients that play a role in terms of just bone health that we want to be thinking of. Magnesium is a very important partner in this whole discussion. Again, it helps our body regulate both calcium and vitamin D. I wouldn't worry too much about supplementing with magnesium or taking any additional. Of course, if it's part of your calcium, vitamin D with magnesium, that's fine. But as long as you're getting some green vegetables, including nuts and seeds and these other food sources, you're probably doing just fine. And then protein is a big part of bone health overall. So just making sure that you are incorporating protein foods, whether they come from an animal or a plant, and making sure that through all of your meals and snacks, there is some source of dietary protein. then you are probably doing just fine with incorporating that macronutrient. So those are high level. I'll stop sharing my screen. Some things to think about from a nutrition perspective for bone health. I know I kind of cruised through that, and we're a few minutes over after 7. So if anyone has any questions as we sort of wrap up, I'll bring Priscilla on. We'd love to answer your questions about bone health in general.
I changed because I'm going out.
Oh, we love that. We love that. We love it. We love it. We love it. Can you share your slides? Yes, Lori, I will absolutely share my slides for sure. In our resources in the Her library, we will post Priscilla's handout and my slides, so you will have access to them for sure. Wine. I've been told not one sip, or 2 glasses a week. Are you talking about bone health in general and its relationship? Cynthia, you can feel free to come off of mute if you want to ask that question or clarify a little bit. All that movement, Priscilla. Well, anyway, here's what we know. Yes, for bone health. Yeah. Can you post Dr. slides too? Yes, and I believe we have permission to share his slides as well. So that will be on there as well because they were super helpful. So we know really when we're talking about bone health and how alcohol plays a role, that increased risk for affecting our bone health, a lot of it comes from a lot of consumption of alcohol. So just in general, keeping our alcohol intake to an absolute minimum. So if you're ingesting something as a celebration or here and there or on a special occasion, I worry less about that type of ingestion in terms of how it's affecting our bone health and our bone density. It's when we start to have that regular consumption day in and day out that we start to think about how is this affecting the longevity. So it's really, I think the risk is higher when you have that regular consumption. Do medications impact bone loss? Been on Synthroid for over 30 years. Trish, great question. So Synthroid does not affect bone impact. It's really the calcium and Synthroid, the food drug interaction. So if you take those two close together, it can impact Synthroid's breakdown in the body, the rate of breakdown. So go for it. Thank you, Priscilla.
Thank you, guys.
We are wrapping up. So I'll finish with just a few questions. So yes, taking Synthroid will not, as far as I am aware, impact your bone density because obviously with our hormones and our thyroid hormone play a big role in sort of the overall bone status. So making sure that your hormone levels are balanced is a good thing, but it's really about that food drug interaction. That's a great question. Any pointers on reversing osteopenia? That's a great question. So again, I'm not a bone expert, but what I know is it's very difficult to reverse osteopenia. I don't think it's impossible, but I think when you're at a point when you have a degree of bone density, lifestyle and medication interventions are so much about slowing down rate of degradation and trying to maintain stability of your bone density. And then also doing things like with Priscilla, where you're supporting overall muscle, you're supporting your bones in general with good muscle tone, so that you're decreasing risk of fall and injury. So I would say, continue to think about these lifestyle changes, nutritional changes, talking to your medical team about are there medical and pharmacological interventions that may be appropriate for that. Okay. Any other questions about anything? I appreciate everyone being here. Perfect. Wonderful. Well, we had some really great questions. And again, I appreciate the suggestions for targeting our metastatic community for bone health in general. I think that's really important, and a topic that I think would be really well received and is important to have a discussion. So as I mentioned, I wrote that on our list. So we will be adding that, I'm sure, to our speaker calendar. So I appreciate everyone for being here. We will share as many of our resources and answer as many of your questions as we can. I shared Priscilla's handout in the chat. It will be coming to you either later today or tomorrow to all of our attendees. But I want to thank you so much for being here with us. And hopefully we will see you at future speaker series and Ask the Experts. I will also plug the Ask the Experts that we have coming up at the end of this month, which we are bringing back our experts that talked about cancer-related cognitive decline. And we will be doing a Q&A session just to talk about that chemo brain and chemo fog and answering your questions. So that will be Thursday, May 26th, starting at 1 p.m. Eastern time, streaming on our Facebook page. So there will be, lots of reminders that will go out on social media and in our newsletter, but another great topic and something we all learn about. So thank you, everyone.